Hello and welcome to the Pharmacy Informatics Professor 2020 with your host, Dr. Armin Simonian. I'm excited to have a return visit by Dr. Tony Dow, one of the modern day pioneers of pharmacy informatics. And I want to invite Dr. Dow back today to talk about his life kind of weekly, monthly, and over time as a pharmacy informaticist in the acute care setting. I think it'll give us some good insights on what it's really like to be a pharmacy informaticist in real life. So thank you again for joining us today, Dr. Dow. Welcome, and I'll hand the microphone over to you, and you can tell us about your job and what you do at your institution.
Awesome. Thanks for having me again. And I guess just to kind of preface about my role, I'm one of 4 different pharmacy informaticists at the institution. We all have kind of some responsibility of things that are for us only, like it's our ownership. However, we do cover each other. So that's a little bit kind of like cross coverage there. So my role, I guess, having a day in the life of is very difficult to explain. So week in the life of actually is a little bit better. So kind of like our Mondays when we start off, I'm part of several meetings. For us, we have our change control meeting. So change control is when the informatics department comes together with all the different stakeholders and people from the different informatics sides, like lab, nursing, physician, all that. And it's to submit a request to have something changed in our EHR system. So part of that is just kind of making sure that these change requests that are being put in don't affect something else. So sometimes we'll get like a provider requesting a certain change in like an orderable or like a medication, not realizing it would impact downstream on how the pharmacist would verify and dispense that medication. So those are kind of things that I kind of keep an eye out for. In the change committees, they last about like maybe 1 to 2 hours, depending on how many changes there are. Sometimes on Mondays as well, we have another meeting called Meds Process, which is pretty much the committee that discusses anything that is involved with the medication use process. And it's all the informatics changes in there. So requests that come in to change how it shows up for barcoding, requests to add a rule into the system, requests to change our power plans or order sets. Power plans is a certain term. Order sets to accommodate like best practices or guidelines, things like that, or even other things that relate to like e-prescribe, so electronic prescriptions that go out, how we configure that from the from our end to send outwards. So anything that kind of touches on the 4 phases of the medication use process, and that's usually a working session, and it includes our pharmacy informatics team, plus a nursing representative, plus a provider representative, and sometimes a lab representative will come if needed. And we also have some clinical people as well. So we have our operations manager and clinical coordinator also sitting in on those meetings as well. So that usually lasts about 2 hours as well. So that's kind of like how our Mondays go. All the extra time on Monday, I do all the other stuff I have to do for like projects and any kind of break fixes that come in, which is break fixes are things that are broken and need to get fixed. So Tuesday is typically my catch-up day. Tuesday is mostly I try not to have any meetings that day if I can. Sometimes I can't help it, but Tuesday is usually when I do the bulk of like my work. So I'll go into what they are later, but I guess Tuesday is kind of like my full like work day of like just 10 hours of just like catching up, going through all the emails, going through our ticketing system that, tickets come in and triaging it and making sure that we have things in the right priority, things like that. Wednesday and Thursday, for me in particular, is spent with a full day working session on oncology EHR. So we are a pediatric hospital where I'm at, and oncology is a very different beast. And there's so many different things that are involved with informatics there. The workflow for oncology is a lot different. There's like a dual verification and everything. Like just for an example, right? When an order set gets placed, it's placed way before the patient comes in. So that initial placement of that order set, the pharmacist needs to verify that entire order set. So it's ready in the system. And then day before the patient comes here, they do another verify. They go in and look at it to make sure all that is ready for that day, and that that patient meets certain counts, certain lab counts, like their CBC results correctly, their chest X-ray has a certain result, those kind of things. And then on the day of, they need to run a report that kind of looks at which patients are due for today, and then they need to preprint all the labels for the oncology meds out so that they can prepare the meds before the patient comes. So when the patient comes and the nurse goes in, and then they do something called an activate. So they would activate that order set for that day of treatment, and then the pharmacy can actually send out the meds, and all that stuff happens. So just thinking about that aspect and not even going into the very nitty-gritty detail of pharmacy, the entire workflow of oncology is just very, very different than the typical workflow for inpatient. So the oncology EHR side of things, we have to accommodate for a lot of different things. There's multiple different rules we have to program into the system that we have to think about every which way something can happen, like a patient that goes between inpatient versus outpatient, a patient not meeting their counts, if they miss their appointment, how to get that rescheduled and not affect like how the doses are dispensed and charged for in the pharmacy. So yeah, that's an ongoing project, and I spend mostly my entire Wednesday and my entire Thursday on doing that, being part of those meetings. And they're working meetings, and part of those working meetings are thinking about the rules that we have to program in. Sometimes we have to run reports, and we would have to write reports. So it's a form of relational database that we use. In Cerner, it's called CCL, but for many people, a relational database, the biggest example is SQL, SQL. So I do have to know some base knowledge of that language so that I could write some of that so that it can pull the reports that we need. And sometimes as well, part of the workflow would, these rules that are in place, they kind of look into the system for information, and then based on those parameters, these rules will have a certain action to them. So what that means is that these reports that we're writing, using the CCL or SQL, those are also written in a way that they get incorporated into the logical rules so that they get pulled into the rules when they run. And once they hit those parameters, then they have an action. So all of that is the technical stuff, but all the technical stuff, we got to make sure it makes sense for the workflow. So we don't want to just throw in a bunch of rules that, will have all these alerts and everything like that, where, yeah, sure, we're warning them, we're trying to keep things safe, but if we have so many rules that they're going to ignore it anyway, then what's the point of putting all these rules? So we do have a lot of discussion and kind of like doing pros and cons and looking at, whether it's really necessary for these things or not. And there's also a lot of discussion about like how much of this can be educated versus how much of this needs a system fix. So yeah, so those are kind of like my typical weeks, which is really weird to say because there's not really a typical because I talked about Tuesday being like my catch-up day, so I have a lot of different projects as well, like continually optimizing our processes in pharmacy that we're still using paper for, and then just getting it into an electronic form so then we can pull that data if we need to, and then show like upper management the value of what a pharmacist is doing. That's part of it. And other projects that I'm currently involved in, one of them is getting implementation of a new like drug diversion software, third-party solution. So it's getting the data in our system pulled correctly so that it can talk to that software. And once that software gets that data correctly, through either our structured query, like through our relational database, or through our Pyxis machines, or a combination of them, then that third-party software can aggregate all that data and perform its own analytics to allow our drug diversion specialists to kind of review to see if like there's any drugs being diverted, or there's a potential risk for drugs being diverted by certain individuals and things like that. It uses like a very, I guess, a rudimentary machine learning AI in its early phase. I don't like using the word AI because, AI kind of thinks it's a whole nother topic, but I think like AI is being thrown around a lot. So it does use like a very early form of AI for that kind of analytics. And then another Another project that I'm on right now is we also are starting a specialty pharmacy. So with that, we are also implementing a third-party solution for specialty pharmacy, which would need to have some kind of integration. Right now, integration is not fully robust, but eventually it will be. And then the other project I'm on right now is it involves investigational drugs, and we are an institution that has investigational drug studies. So we currently are not using a third-party solution, but by having a third-party solution, it kind of puts all that information into one spot, and then in a way that can be matching what is required by the drug sponsors and matching what's required by law, and all the requirements of those studies. So we follow those guidelines, right? So right now, the process, I guess as of today, the current process is trying to get our interface up so that our EHR can send that information and map to the right protocols, the right studies on that third-party application. So we are currently using it as a standalone. We're trying to get it to be integrated. So those are the kind of like immediate upcoming projects. A longer term project, which I may or may not be part of, it might be my colleague, is getting our pumps to be interoperable with our EHR, smart pumps. So my last institution that I worked at, we did have that, where the pumps would have a two-way communication with our EHR. So when a nurse scans the medication, scans the wristband, scans the pump, then the pump will pre-populate with the order information for that medication. And then, guardrails and everything is within the pump's drug library. Whereas currently at my place of employment right now, it's only the smartphones are there, but then it's not like a two-way interoperability. So there's no data going from the pump going back to Cerner that tells you what rate was being infused. There's no like scanning of the pump to get pre-population of the medication. That is something that we do have planned for the future, but because we are a pediatric institution, it does require us to kind of like rebuild our entire drug library to kind of meet the parameters that are required to have that kind of integration. So it is something in the future. It's not something right now, but just one of those things that I may be involved in the future. So I mean, there's a lot of things. There's a lot of things that happen all the time. The other things that I mentioned before was break fixes, which is like if they can't find an order in the system, like why isn't it there? Or if they're trying to place an order that's an e-prescribe and it says, hey, this is obsolete. Why is it obsolete? What's wrong? What's going on? Or why is this order set like not able to be initiated? A lot of like these little things that are they're kind of like you would think that they're quick issues, but then they're kind of like you can put a band-aid on it, but you really need to figure out the source of the issue, which may take longer. So there's a lot of that. There's a lot of triaging things. But yeah, I mean, do you have any questions about what I do? Because I know I said a lot of things, and
Yeah.
I'm
Well,
sure
for
you've
me,
experienced it.
yeah, personally, it's very validating and interesting that what you go through on a weekly basis, very similar through what I went through when I was full-time as a pharmacy informaticist at the corporate level of a multi-hospital system. And on every Monday, we had a clinical informatics meeting where we talked about change management on our EHR, and that was a 4-hour meeting. Tuesday morning, we had a ticket management system meeting where we talked about ranking those requests to see which one was going to take priority and be done first. And then on Wednesday, I had a 4-hour meeting, Pharmacy Informatics Council, which was really focused in on pharmacy informatics. And the rest of the time was, completing tickets and answering emails and then working on projects of systems to implement. So thank you for sharing, because that was really interesting to see that what you're going through and what you do on a weekly basis is very similar to what I was doing. So kind of gives us a good idea of what pharmacy informatics position in an acute care setting might be for everyone. So
Yeah,
thank you
and
for
I
all that
think
great information.
yeah, and I think like one of the things that I didn't realize in the beginning was how many meetings I'd be part of.
Right.
Um, it's and I was always like a shy person. And I was, when I was first starting out, and I spent like a year or two really, really just trying to learn as much as I can, and just reading on my own time, like outside of work, about how to do things. And I I was part of so many meetings. One thing I didn't mention was PNT as well. P&T and Med Safety Committee.
Mhm.
And I think like because of the role, I've gained a lot more confidence in public speaking, which I never really understood, or not understood, but I never really saw myself getting into that kind of like comfortability with speaking with others.
Right.
Um, and it's not just like the reason why I'm saying this is that I don't want students or people who are new to the field feel discouraged that because you're not really a people person, you may be turned away from this kind of role. But more of that, when you're in the role, it's kind of a way to kind of like improve yourself. Um, I don't think I would. I think like if I stayed in like a kind of like I don't want to like say this in a way that it knocks on like inpatient pharmacy. No, it's not supposed to. I really respect inpatient pharmacists, but I mean for me, right, because I was not really a people person and I was really shy. If I was in the inpatient setting and not really interacting with big committees and interdepartmental meetings, I don't think my skill set for speaking with public speaking would have been improved, because when I was in this role, it kind of forced me to, because I'm placed in that setting and I'm just like, okay, it's almost like a feeling of sink or swim, but
Yeah.
it's I actually enjoyed that was what I went through, so.
Awesome. Great. Thank you for sharing that personal information. And I think that's also very helpful for our viewers. So we're kind of at the time limit. So I'll just thank you again for being here, Dr. Dow. And I'll say to my viewers, if this was interesting for you, please like the video and subscribe to my channel. And in the meantime, stay safe, stay healthy, look after the health of others, and I'll work on more episodes and hope to see you next time. Take care.